All right. Well, good morning, everyone. Thank you very much for joining us today for this panel on equitable access to behavioral health care and 988. My name is Nishi. I serve as Chief Clinical Officer at Bamboo Health. And we have two fantastic panelists with us today, Madhuri Jha as well as Brandon Johnson. First, Brandon. Brandon is a public health advisor to the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, where he leads efforts around suicide prevention with states, territories, and tribes. And Madhuri serves as the director of the Kennedy-Satcher Center for Mental Health Equity at the Morehouse School of Medicine. I'm going to dive right into our questions. 988. It's being equated as the equivalent of 911, the behavioral health version, a way for people in crisis or need to reach out and be connected to definitive assessment and behavioral health treatment. As they say, it's someone to call, someone to respond, and a safe place to go. It doesn't always happen with 911, as we know. A police officer or an ambulance takes you to the emergency department. Many regard this as an attempt to democratize access to behavioral health care. So we're 4 months in since the launch in mid-July. How's it going?
So I want to jump in with that?
Yeah.
Yeah, I mean, I can jump in from our perspective at SAMHSA and the U.S. Department of Health and Human Services. Right now, we're really excited about where things have gone so far. We've seen, just looking from our most recent data, looking at August last year to August this year, we've seen about a 63% call increase. We've seen in our chats, we've seen about close to a 200% increase time pointed from last year. And we've also seen over a 1,000% increase in text utilization, particularly among young people. And so obviously this is square one. This is still in its infancy, but the uptake so far has been really encouraging, and we're excited about where things are going. We're continuing to, listen to community, and I'll talk about that more as we go along, create opportunities for us to engage in terms of equity. We're still working with our crisis centers, their staff, to make sure that everyone is staffed up and it is trained adequately in issues and challenges that face particular communities as they're engaging with 988.
Madhuri?
I'm going to take a quick poll. How many of you all knew what 988 was before you came to this talk? Show of hands.
It's pretty good.
It's pretty good, but it's an indicator, too, that one of the things that we're looking at from an equity perspective at Morehouse School of Medicine is how many people who need to have access to a crisis line get access to a crisis line. So we've been supporting SAMHSA as well as advisors to see how there's certain populations who've historically just been unmet by crisis response, overall healthcare services. It's no surprise that those include BIPOC communities, the queer community, older adults, non-English speaking folks, refugees, immigrants, people who are physically disabled, people who are neurodiverse, right? So we're trying to provide states with recommendations on how they can tailor their 988 public health communications, for example, to make sure that those communities are not met with an unwarranted response.
Great. Now, Brandon, at SAMHSA, you have been supporting states with respect to 988 funding and implementation now for around 2 years, if not longer. What are you doing with states specifically around health equity?
Yeah, absolutely. There's so much happening. I'm going to try to keep this as short as possible.
No, please.
But there's so much happening around equity in SAMHSA space, and equity is a cross-cutting issue at our agency and within the work that we're doing, not just with 988, but as a whole. And we're embedding that equity, that perspective through everything that we're doing, including 988, right? So working with states and working with their communications folks to really understand how to access the communities that Madhuri has, really talked about, and, getting access to them and encouraging them to, be in community, right? As crisis centers, you're in community. You understand the community better than we do at our perspective in the clientele that you have. And so I think one key aspect of it is even, are you checking your data? Are you looking at the data to see who you're serving? Do you know your community? Does your community know you? Do they know what services you provide, how to get access to 988? And so we're doing a lot of work on our end also with this as well. The Press 3 option for LGBTQ plus youth and young adults and working with the Trevor Project is live. So that's currently live. So if you dial in Press 3, as a young person who's LGBTQ plus and wants to access the Trevor Project, that has already started, and we've seen more than we had expected in terms of uptake with that. So we're really encouraged by that. Another thing that I really wanted to highlight that we're doing is that SAMHSA, in partnership with the Suicide Prevention Resource Center, that we fund, the National Action Alliance for Suicide Prevention, and the Ad Council, we're doing a formative research project now to really engage on a quantitative and qualitative side to engage these communities that we're talking about reaching. And so with this project, we're engaging key informants and putting out surveys to engage with populations such as African-American youth and young adults, Hispanic youth and young adults, LGBTQ plus young people and adults. And one piece of it that I'm really encouraged by is that we're engaging with individuals with lived experience. So if you've experienced suicidal crisis, if you've made a suicide attempt, we're engaging to understand how can 988 meet your needs? Yeah. How can it be better? Are there barriers in particular? And we're also engaging with American Indian Alaska Natives. I wanted to put that out as well, and older rural adults as well. So we want to know, how can we improve this? Like, how do you feel about it? How do you feel about crisis intervention as a whole? Are there historical traumas that prevent you, from reaching out to a crisis line? So these are some of the things that we're doing, and we're even embedding it throughout all the work that we're doing. We recently had a meeting in August on Black youth suicide, and we dedicated a particular portion to that. And Madhuri was gracious enough to be there. We even engaged there. So, like, how can 988 be better for you? And hear from experts and people in that community together. So we're really making the effort. This is important to us, right? And we're putting the strides in to really address this and to hear directly from those communities, because if we're doing it from our perspective of how we think it should go, and it's not what the communities are feeling, what they're thinking, and why they're not accessing it, then we're really not about the business of equity. And so that's where we are with this.
Yeah, the first step towards improvement is obviously evaluation. So Madhuri, you and your organization recently put out a policy report in conjunction with Beacon Health Options around state performance, baseline performance for 988 with respect to health equity. What can you highlight for us from that report?
I think there are some things to put into perspective when it comes to communities that have not been reached by our crisis response system. So I always come from a lens that I was an assertive community treatment director in New York City through COVID, right? So COVID-19, across healthcare, we know none of us were trained for, but we also had to think very differently about responding to crisis with folks who might be, for example, experiencing homelessness, or might be justice involved, or might not actually speak English, right? And even if someone has language proficiency that's stable in English, when you're in crisis, you're going to want to go to your native language, right? And it's very, very tough to literally answer, are you hearing voices, because I hear your voice as the EMS person coming to me, and then experience an unnecessary hospitalization for that, right? Because I'm actually just hearing you speak. So I think the barriers that we have to think through are really important so that we don't continue to perpetuate them. 75% of US counties are what's called a mental health clinician shortage site. That means that not only are there no MDs or nurse practitioners to prescribe medications, it's very hard to even find a clinician who can sit with you and talk to you. So we've made recommendations to include peer recovery specialists on mobile crisis teams. It's an evidence-based intervention where someone who has lived experience, who's been able to access the system, is able to represent you, sort of be a buddy with you through that process. We've recommended the use of medical translators, as well as being very important. SAMHSA is working hard to try and get 988 accessible in Spanish, but we know that there's so many other languages that are also spoken in the US. I think the last thing to think about, too, is telehealth service delivery being a real big ally in 988's administration, and what we can do if somebody does need access to an outpatient service in their state, can't find the service, can they see a telehealth provider temporarily across state lines so that they could have their needs met? Some folks don't know, but certain tribal reservations are not even accessible by car. They're only accessible by helicopter. And currently, suicide is the second leading cause of death amongst Indigenous youth, African-American youth, Hispanic youth, Asian youth, youth overall, right? So we have a crisis right now in the US that 988 provides the true potential. It's a historic moment in our time to really think through, how do we get kids, families, adults access to care for the first time ever?
Yeah, Yeah, so let's talk about the mental health professional shortage areas. As you said, 75% of the counties in the U.S. are a shortage area, and a shortage area is usually related or is strongly correlated to rurality as well as low income. So 988, a lot of people, the naysayers out there, say that we're creating another silo of care, the acute, the crisis end. If you've got the majority of the U.S. being a mental health professional shortage area, someone calls in, then what? Where's that longitudinal care? What is SAMHSA doing? And Madhuri, what are your recommendations in terms of providing that longitudinal care?
Yeah, I can jump in with this, and you put it, perfectly in the beginning. Some place to reach out to, someone to respond, and somewhere to go. We're putting a lot of investment into certified community behavioral health clinics, so our CCBHCs.
Yeah.
There has been a monumental, increase in funding through the Biden and Harris administration. So about 300 million increase in August, I think, came to our CCBHCs, and so they're in 46, I believe, of the 50 states, and they provide this type of care specifically. If people don't have the ability to pay, they're still able to access those services. So similar to a FQHC, a federally qualified health center, they have those services. And in looking at the data, the vast majority, over 90% of our CCBHCs, have some type of crisis stabilization unit. They're connected, either they have it or can refer individuals to crisis stabilization units to get people access to mobile crisis centers. I mean, a lot of them have mobile crisis units that can go out and do that work. We just released a grant very recently that just got funded. We funded 10 states to do crisis intervention work, particularly to build supports that move away from law enforcement involvement, because we know that that's a critical, deterrent and barrier for a lot of our communities that we've talked about to access care. And so we're trying to build this piece up, because if we can get mobile crisis centers engaged in our crisis centers, many of them have mobile crisis units, and then have a place such as a CCBHC with those crisis stabilization units to be able to get that care. And I know about over 90% of them are doing care specifically that is culturally sensitive, using cultural humility, cultural competence in that work as well. So it's critical. And again, they're in community, right? They can build those relationships. They work with the schools. They have access to the community to say, what do you need from us to be able to get you this care?
Just to add to that too, I think that there's, tremendous opportunity to understand metrics, in a different way when you look at 988. So 988 currently is anonymous. You're not geolocated. You have the option. You're not going to be identified of where you are. And so we've been working with SAMHSA and understanding, how do we actually figure out who's calling this number? Because truthfully, it's very hard to get communities very averse to calling 911 to just jump on to say we're going to call 988, right? And we know certain communities have been very poorly met by that. I think with regard to the workforce piece of it, university training centers for us is a big recommendation for partnership. Giving students incentives to not only be embedded into crisis centers for their internships, for example, for their training opportunities, but perhaps create an incentive for them to have guaranteed employment, for example, when they graduate with their social work degree, things like that. But I think in addition to, there's just certain trainings that we think are mandatory for all facets of the continuum of care across 988, going from the dispatch who gets the call, to triages that phone call, to the assistant who's managing the paperwork for that crisis center, really should all be trained in mental health first aid, not just because it's an important skill I think everybody should have, but I think when you have the perspective yourself to know, this is what I can do to de-escalate someone when they're in crisis, your buy-in to the success of that intervention actually hypothesizing would increase, right? Because you know that you're part of that system, and you have to have people feel like they're part of this. And I think that's why 988 is a huge opportunity, again, to break down other kinds of workforce silos where we've, had a vertical hierarchy of investment in care, where now we can actually see this as more of a true interdisciplinary effort to meet people's needs in the communities, which really takes what we do well in hospitals and embed them into mobile crisis care, phone crisis care, telecounseling, things like that. And the last thing from a workforce perspective is, we have to build on what exists in communities. That's going very well, right? So in this policy brief, if you all have an opportunity to read it, there's healing circles that have existed in certain communities of colors for very, very long time that should be leveraged as amazing bridges to folks to be able to seek someone that they trust, that they feel can be a healing person for them, and then connect them with a mental health professional that can give them the appropriate care to meet their needs. So we want to build on those strengths. I think we talk a lot about resiliency. Resiliency is a function of trauma. So we have to acknowledge both and find ways to measure not only the adverse outcomes that people have, but as well, what are they doing really well to be able to survive and exist? The last thing I'll say too is it's just really important with our metrics that our metrics don't do more harm than they do good. It's very dangerous to say that race or ethnicity, for example, is a risk factor for crisis, right? So we want to actually identify and take time in these environments where we see uptick of suicide, uptick of crisis calls, what's actually happening at the community level that's there that we can actually tackle from a policy perspective or a local intervention, as opposed to just sort of being in the realm of what we've done historically is bracket certain groups to be at risk, and actually acknowledge that there's strengths that they have within their own communities that we could all stand to learn more about.
So let's shift gears to technology. 2 years ago, when we at Bamboo were starting to look at crisis care and leveraging our technologies to support 988 and beyond, we were one of maybe two technology vendors threading together the crisis care continuum with technology. Now, same thing. I could say maybe there are 3 vendors out there that are doing something similar. Why is that? Why are there so few technology vendors involved in crisis care and behavioral health more generally? And you've got a number of vendors here in the audience. What are your recommendations? Where do you all need help?
So one thing I will say is that we just don't have enough psychiatrists or mental health clinicians, period. And so I think one of the things, for example, I supported CMS to do an assessment of whether or not telehealth service delivery, creates equitable access to mental health services. It was almost unanimous that the access goes up if we increase technology platforms. What's not unanimous is if people feel that the quality of care that someone will receive when they're in crisis will actually be what they need to be. And there is some truth to that, right? Like there is a mobile crisis team component to 988, which is really crucial because there are times where someone needs to be seen in person, right? You have to actually go there. And all of that is to de-escalate so that they're not unnecessarily hospitalized or, even worse, incarcerated or have some other kind of adverse outcome because they're not met with the need. So I think that's one of the challenges that platforms are having is how do we make sure from a liability perspective that we're able to be responsible and manage the risk of someone being in crisis and be able to have limits in place enough that we can say this is the max that we can go, but we have a protocol in place where someone locally can have their needs met. Which are things that I'm hearing because we've had so much outreach from folks to say like how can technology help?
Yeah, absolutely. I think that I totally agree that there are still some spots of, what is beneficial, what is going to be helpful, within communities, specifically around the technology issue. And, I think for us, it's something that we've encouraged with our states. So as we're engaging, with states when they're developing, finding out their metrics, are they creating dashboards? Like, how are they, getting their measurements and things like that? I think technology is a key piece there and something that we heard loud and clear of why we needed to improve our tech services, right? Just a simple thing because our young people, that's how they access individuals, right? And so we want to continue to hear from folks and see how we can incorporate this and also encourage our states to look at those opportunities to build in technology into the work that they're doing.
I wanted to circle back to something you mentioned about 988 not being geolocated. That's rather controversial. As you all know, we have cell phones. My area code is Baltimore 410. I live in Washington, D.C. If I were to call 988, then I would be put through to Baltimore, right? And so the problem with that, obviously, is that they have no local context or insights. But then the opposite argument is that I remain anonymous and I don't risk having someone show up to manage me, assess me as a surprise. So interested in both of your thoughts regarding this controversial issue.
So our policy brief was also a function of a large leadership experience survey that was anonymously sent across the country to various types of folks in the behavioral health space. And we asked an honest question, do you think 988 should be geolocated? And there were very strong answers towards no, and I think those are folks that are working specifically in communities where we currently have legislation state by state. For example, if you identify openly as being part of the queer community as a child, your parents might be met with Child Protective Services. We want to make sure that it doesn't do more harm. On the flip side, we also heard response from folks who say, if someone's undocumented, they need to know where a safe place for them to go is to get culturally attentive care to their needs. We recommend an opt-in option to be for geolocation that make it the caller's choice. The caller should be able to say, I would like to be geolocated because I want a local resource, or I would prefer to remain anonymous and just talk through this on the phone. There's a lot of evidence that these things can be de-escalated on the phone. So give the caller the choice. It's patient-centered, it's client-empowered, and it also allows them to see their pathway to success on their own terms.
Yeah, that makes sense. Brandon.
Yeah, so there isn't geolocating now. It's something that we, will have to continue to give thought to, and the policy brief, did a great job of doing that, but thinking through where there's potential, privacy issues, but also how do we deliver the best care for individuals. So right now we're working on improving that geo routing that you just talked about of, picking up your area code and getting you to the right crisis center is something that we're really working on now. Geolocation isn't, we're not at that step yet, and there's a lot of consideration that needs to go around that. So that's kind of where we are currently.
Great. All right, well, we're at time. Thank you for joining us. Thank you very much for sharing your experience and your insights. This is going to keep going on at our booth. We're at booth 2030, right, by the way, that way. Not that way, directionally challenged that way. And we've got people who can walk you there. So we'll continue the conversation there. Thanks again.
Thank you.